I'd like to acknowledge the local custodians of the land in which we meet this evening and honour elders past, present and emerging. I'm Melissa Wilkinson from the education team at the PHN. Welcome everybody to tonight's session. We're here tonight to look at e-prescribing, show me the buttons. That should be interesting and extremely relevant at this time. Just a bit of housekeeping. We have a questions box to your right-hand side of the screen. If you could drop any questions in there that you'd like to ask, this is your opportunity to do so from our presenters, to ask any questions that you think are relevant or that you're burning to be answered. Also, we are being recorded tonight and it will be available in our education library through our website. And at the end of the session, there will be a poll as per usual, and we strongly encourage you to complete that. Your feedback's really important to us, and that's how we base further education and monitor what we're doing. So really encourage you to send that out and complete it. Thank you. So I'll introduce the speakers tonight. We have Peter Mullen from the PHN, he's our Digital Health Officer. Welcome, Peter. Ben Wilkins from eHealth Coach. Welcome, Ben.
Hello all, thank you.
And Dr. Michelle Redford, welcome. She's from Black Box Doctors. So I'll hand over now to Michelle to start us off for this evening. Thanks, Michelle.
Thanks, Melissa, for that introduction. Yes, so as Melissa said, I'm a GP, so I'm on this multidisciplinary panel representing prescribers, and we're fortunate to have a couple of subject experts with us, Ben representing pharmacy and Peter representing practice management. So I've definitely got the easiest part of this, because the prescribers part of this, e-prescribing, is definitely the easiest bit. So there's a little bit about me there. I'm not going to be talking about parkrun tonight, that's a shame, but that's about social prescribing. Today we're talking about actual prescribing, and I'm glad to be co-presenting with Ben. I'll hand you over to Ben.
Terrific, thanks Michelle. As you can see, I'm a pharmacist there. I'm in clinical lead at the Digital Health Agency, and I'm involved with regulation and the local health district on the board there, and Hunter Primary Care. And Michelle and I are quite comfortable to tag team. I'll cover a bit more of the patient journey, particularly from the pharmacist's view, just so that you can see things from the start with Michelle, following through more towards the end with what the patient will actually be receiving at the pharmacy end. Just to introduce what's happening across our nation, there's been a national digital health strategy. There's 7 pillars, there's 44 strategic objectives, and we are talking about just the one, of course, tonight, the electronic prescriptions. And the purpose of this slide really is to give you an insight that there's been a whole wave of progression for a number of years, and the nation's really trying to bring together 600 odd different systems and getting more interoperability with a stronger level of security. And of course, that's to improve the clinical journey for the patient and to fit it within the workflow for clinicians. So I just thought I'd give you that general overview, and of course, we'll narrow down onto the e-prescriptions.
And e-prescribing is a hot topic right now in general practice for a number of reasons. I think most of us will be pretty familiar with this kind of image if anyone's had to work from home. This is how it felt a bit for me last year when I had rhinovirus and I had to work from home doing telehealth and printing out prescriptions and trying to scan them and email them and find the email address for the pharmacy, etc. So I think, e-scripts take a lot of that work away, and I would really encourage any general practice who hasn't already got on board with e-scripts to do so and to think about what your workflow could be using e-scripts. So it's a hot topic for the reason of working from home, which we all need to be ready for at any moment, I think, now, and because of telehealth, and because patients are, we're trying to keep patients out of the surgery as much as we possibly can. So e-scripts is another way of doing that, so that people aren't coming in for paper scripts. So those would be my 3 main drivers right now for getting excited about e-scripts. So what are we talking about with e-prescribing? So if you're not familiar already with e-prescribing, from a prescriber's point of view, it's really quite straightforward. Instead of printing out a paper script and signing it, you generate a token, which looks like a QR code. Now that's not actually the prescription, and we will talk a bit about that later, but that allows access to the prescription. You can decide with the patient, so it's the patient's choice really, how they receive that token, and that can be via email directly from your clinical system, or you can SMS it to the patient. So most of mine, I would say, are SMS'd, or you can print it out on plain paper, which can then either be physically given to a pharmacy or faxed to a pharmacy or that kind of thing. And there's a bit more magic in this whole thing about the encrypted prescription, which Ben will talk about later, but the token is allowing access to this prescription. It's not the actual script. Then,
and that's a really good point, Michelle. We'll cover that and expand on that in all the slides, so it's really clear for all the prescribers.
Yeah. Thanks, Ben. That's really helpful. Yeah. So then for the patient, they get one token per prescription item. So it's not like with a paper prescription where you might have multiple items on one piece of paper. They get one token per prescription, per item, and then that can be scanned at the pharmacy and dispensed. So it's actually pretty straightforward. In the pharmacy, it is single use, so it's a bit like a concert ticket or something like that. Once it's actually been scanned, the thing's locked. You can't keep going back and scanning more and getting your other mates in with the same concert ticket. And then the software, the pharmacy software, generates the repeat token. So the prescriber has nothing to do with the repeat token. That we don't then have to issue that. If you've issued a prescription with 5 repeats on it, then those 5 repeat tokens will come out automatically without intervention from the prescriber. So that's my little
Michelle,
run
that's
through.
a good point. Those tokens will come out one at a time. So
yeah,
of course, you can't be reproducing an old token.
Yeah, and it wouldn't work if you tried to rescan an old token either.
Indeed, and we've got some shots on phones actually, just so that prescribers can see what that looks like.
Okay.
So I think, Michelle, there's a point of clarity that's really important that sometimes causes confusion. And I know when I've been speaking with a number of doctors across the country, they've often said to me, I'm already doing e-prescriptions, but often they're not. And that's why I just wanted to run through the 2 types of legal prescriptions. There's the paper that we always know, you print it, you sign it with a pen with your own signature, and that we know very well. The electronic prescription has inbuilt identifiers for the premises, the practitioner, and the patient, and obviously there's security within the Conformance software. And the e-prescription token is really just a representation of the script, because that token needs to access the data set that's in the prescription delivery service to bring forward the legal form of the electronic prescription. So in summary, paper's one form of the legal document, and the electronic prescription, they can be the individual token that the patient might carry with them on their phone, or it could be up in the active script list, colloquially the secure cloud. But whether it's an individual token or a bag of tokens of many scripts in the active script list, they are the same legal document.
And we are going to talk a bit more about that active script list a bit later on, because not everyone will know about an active script list already.
Really good point. It is actually unfolding a little bit, but the more common one will just be the token that the prescriber will prescribe and send as an SMS or an email at this point in time.
And
so,
just thinking about, sorry, Ben, just
yeah,
thinking about about that it's really just two forms of a prescription. You know, that then demonstrates really that you can do anything with an e-script that you can do with a paper script. So you can do S8s, you can do Reg 24, you can do authority scripts, all of those things, because they're interchangeable in that way.
So you can only have a paper prescription with the signature in pen or an electronic prescription. You can't, the patient can't swap between them, for instance, for repeats. Yeah. So it's just to set in people's mind. And the reason we want to raise the paper prescription is because there's been so many regulatory changes over time. And a lot of pharmacists and prescribers keep up to speed with this on the PSA website. That's the Pharmaceutical Society of Australia. And they outline it on their tabs quite clearly. So if you're not quite sure what your legal requirements are, this is a potential way to keep up to speed. So the digital image prescriptions, and I'll get you to talk a bit more about these, Michelle, in a moment. That is not an electronic prescription. It is a paper prescription that's printed, signed, and a copy of it might be sent as an SMS, as a digital image, or as an email. So they do not, they're not allowed to be done for S8s and S4D drugs. So prescribers would be aware of that. In all states and territories, it currently finishes in September, and there's likely to be an announcement that we can all be aware of in that regard, because there could be an extension. So have you heard anything more about that to date, Michelle?
I think there are rumours it's extending to the end of the year. Is that right, Ben?
Look, that could be. I don't believe it's actually been formally announced at this point. The current date is the 30th of September. However, we do realise that there's a number of prescribers around the country that don't have Conformance Software. So if they're doing telehealth, they can't send an e-prescription, and the interim arrangements with the digital imaging script will probably need to continue. So that would make some sense. So just to come back to the e-scripts, there's a couple of points for people to be aware of. Firstly, when it's sent to the patient, and I should say 2/3 of scripts across Australia are sent by SMS. That's the patient's preferred option. And when that SMS is sent, it only shows the patient's initials. So there's no prescriber details, there's no addresses. So it's this is just how it presents if it's an ERX prescription via that mechanism, or a MediSecure. They're slightly different, but the same outcome. And the patient will receive the text, they can click on the link, and they can have their token pop up on their phone. And the tokens are pretty similar. There's slight differences whether it's MediSecure or ERX, but from the patient's point of view, they can turn up to the pharmacy and have it scanned, which draws down the legal form of that e-prescription. And the if it's via email again, it just has the patient's details. So I have heard instances where prescribers have sent them to a pharmacy because that may have been the patient's preference at the time. But the pharmacies really can't actually tell anything unless they click on and scan and download the whole prescription. So sometimes that's quite a clunky way to approach it from the pharmacist's view. The third way outside of SMS and email for an e-prescription to be presented is printed as an evidence of prescription, and that has the QR code. The main difference here is that it actually identifies the prescriber and the patient. So some pharmacies might actually use that as part of these telehealth options and the instead of the interim arrangements where you print and sign and fax, etc. Michelle, I just thought you might talk about your experience last year and trying to work out which pharmacies were actually doing e-prescriptions and what that it's changed now, and we'll talk about that in a minute. But I just thought we could draw on your experience last year.
Yeah, so I suppose last year when I was having to work from home, I was doing image-based prescribing for everything. So that means printing out the script, scanning it, signing it, scanning it, all of that stuff. And it was hugely painful and slow. And not just that, but the scripts then have to be posted out. So then there's a whole another step of having to post out the scripts. Whereas yesterday I had to have a COVID swab again, unfortunately, and had to work from home. And I generated one piece of paper all day because all my scripts were e-scripts direct to the patient, apart from one, which I had to print out and get faxed to the chemist. So I used this, I still did it as an e-script. So I did it this way with a faxed evidence of prescription. It wasn't urgent, so it went today after my COVID swab was negative and I was back at work. And that means that I then don't have to follow that up with anything. So I don't have to then post out a paper script or anything else like that. It's much cleaner, much neater, it's more secure, much better workflow for admin and everything. So that's a huge difference. As part of our transition into e-scripts, we actually contacted all the pharmacies in our database, which was 75, I think, pharmacies locally, which just goes to show how many pharmacies a big practice deals with. They're scattered. And so knowing people's preferences is actually really hard. You know, how do the pharmacies want to receive communication? It's really hard. So out of those pharmacies, I think all but 2 or 3 were set up to receive e-scripts. There is some variation in how, as Ben says, you know, how easy or not easy it is to access various things. I think some pharmacies don't necessarily have easy access to their email when they're working. They might not want tokens appearing in lots of different places, you know. So there is some collaboration needed with your the main pharmacies that you deal with, just to try and make things a bit easier on the pharmacy side, because whilst it's fairly straightforward on the prescriber side, it doesn't sound very straightforward on the pharmacy side. Ben, is that fair to say?
Yeah, it is not a seamless workflow, and it's quite more involved at the pharmacy end, and I'll just give a brief outline of that later on. Look, I think your experience last year demonstrate it was a new system and there was a bit of exploration to do, and we're going to bust a myth pretty shortly so that you don't have to think about that any longer, because it's very simple and it's now integrated across pharmacies. So I'll give you a clear take-home message on that shortly. And Michelle, you touched on this earlier, and this is just a graphic that if a prescription, for instance, has expired, there is no QR code anymore. It cannot be downloaded as the legal form of the e-prescription. So if it's expired, there's nothing. Equally, if it's already been dispensed, there's no QR. And we're about to run into some of the benefits of e-prescriptions, but patient safety, medication safety is a clear one, because unlike a paper script where the repeats can float around for quite a while and perhaps be dispensed incorrectly, the original prescriber has the capacity to cease an e-prescription, and it cannot ever be dispensed because there is no QR code, there is no script anymore. So
I love this about e-script.
Significant advance that we haven't had to date.
Sorry, Ben, I love that about e-scripts. I got so excited, interrupted you, sorry. I love that about it,
No,
because there's none of this,
take
none
it
of this
away.
having 10 milligrams of amlodipine and 5 milligrams of amlodipine all at the same time when you've reduced the dose. You know, you just can cancel the old one, and we've never had that functionality before. So it would have been trying to shred the scripts or ring up the pharmacy and get them to shred them or whatever. So I think that's really huge. So this is just my quick little run through of some benefits for prescribers. Honestly, it's so easy. We implemented it in practice with very few hiccups back in sort of March, April. As Ben said, you know, the security is written in. You can do it really easily with telehealth. It actually works really well to support telehealth, and that's also one of my favorite things, that you don't have to do multi-step processes for a simple thing like getting a script to a pharmacy. You no longer have to, with an e-script, you don't have to write on it. So if you're doing an S8 prescription, then you just have to re-enter your password. It prompts you to re-enter your password, but you don't actually have to write it out in words, figures, or anything else like that. Hopefully we have fewer lost scripts once people get used to managing the tokens, and we will talk a bit about that. Ben's got some stuff about that. And, you know, infection control right now is really important. We're trying to minimize the number of people who come into our building, and we certainly don't want people just coming in to get a bit of paper if we can do it another secure way. And actually, my patients really like it. I think most people want to receive things as a token via SMS, but some of my patients are really happy to receive it by email and then print that out and then take that. So that's another way where so it's a bit of a transition, a bit of having a bit of paper still to present. And yeah, reduce transcription errors, because of what happens at the pharmacy end. That's important as well. So I think there are very few drawbacks.
And those transcription errors, we all know they're possible at any stage in the patient's journey, even in the acute care or discharge, writing a script, even at the pharmacy dispensing. So that's a real critical factor for medicine safety. I just wanted to pick up on your comments about S8s, and with an e-prescription, there's a significant amount of administration saving. So not having to print it and write it in words and numbers, and as you mentioned, going through that faxing process, which I have actually had practices do a time in motion on that, and it's often quantified at about 15 minutes of time by the time it goes through the whole process. So with a Schedule 8 drug as an e-prescription, you just prescribe it, and instead of pressing print, you send, and it's done. So that's a significant admin saving, which I'm sure you're living, Michelle.
Yeah, and I think as well with S8s, we also sort of required people to come and pick them up in person. So like if we were generating a script, we had that as our security. So you're actually, there's all sorts of benefits from the S8 point of view, because you're getting it directly to the person, and then if that person wants to forward the token or something to a family member or relative to go to the pharmacy, then they can. So, and it's still secure, and you can cancel, of course, if you've accidentally done something, you can cancel scripts. I would recommend you speak to the patient before you do that. But that's another thing. If that's another particular thing with S8s and other repeats that you might not really want, you can cancel them after they've been dispensed. Cancel future repeats, I mean.
Michelle, infection control from the pharmacy side is a really good point too. With a paper prescription, giving the patient a pen to sign and all of that, e-scripts averts that. So that's often an advantage, especially in our COVID world. So look, I didn't get the snapshot for today's truth on the volume of e-prescription. So this has been produced with permission of the agency. So by the 17th of August, we had actually cracked 15 million tokens generated across our nation. And you can see the volume, how they've increased from prescribers. And interestingly, the dispensing does lag, and it's not just because of not getting it filled immediately. This is just a general bit of information. Studies show that between 80 and 88% of scripts that are prescribed by doctors aren't actually filled at all. And the studies suggest they're filled and taken about 75% of the time. So I think that's a real opportunity for communication at the prescriber level, particularly considering health literacy, because 1 in 4 patients may get it filled but still don't take their medicine. So I just thought that was worth sharing. But there's definitely a lag there. This week, between the 10th and 17th of August, was the largest number of tokens generated in our history, and it was 720,000. So e-scripts are happening in our nation, and in fact, this year it is likely to be 1 in 10 prescribed items. So it's moved pretty quickly in many regards. The next bit I wanted to share is a few weeks ago, this is the volume of GPs that had done at least one e-prescription, and it's well over 70% now. And we actually have, I would dare say that we've actually got 999 out of 1,000 pharmacies that have done e-prescriptions. So the message there is you can be very confident that if you prescribe a token, an e-prescription for your patient, that they will be able to get it filled anywhere. I do know that there's about 6 pharmacies on the Central Coast that don't, because they don't have Conformance Software. That'll be changing in the short term in our region, but across the nation, they can be filled almost anywhere. So that's a good take-home message. And look, on the right here, I just want to demonstrate this. There's new pharmacies coming on board each week since May last year, and it's flatlined in both of these graphs because there are no new pharmacies really coming on board because they're all set up. Prescribers, though, this is the prescribing curve. A couple of weeks ago, we had 1,200 prescribers across our nation do an e-prescription for the first time, remembering that a lot of the specialist software isn't conformant yet. So that will just continue to grow as we move on forth in 2021. The next bit on this slide I just wanted to share with people is the active script list. Now there's 2 steps to it. A patient needs to consent to register to have or to be on the active script list, and then they need to consent per provider. So at a pharmacy, they might register, then they consent with that provider. When they go to the GP or the specialist, they would also need to consent for their e-prescription to go up to the active script list. So that mightn't make sense immediately, but there's quite a number of webinars that are on it, and we'll show those at the end. And you can definitely contact the PHN or look on their website and the digital agency's website. There are a lot of webinars on the active script list already. Now, just to give us a number, there are already over 30,000 Australians almost 3 weeks ago who already have an active script list. So it is happening, it's organically occurring, and as you would all know, you can always stick with a paper script. That is not a problem. But if you choose to do an e-script, you can send it to the patient as an SMS or email, or if they've got an active script list, you can actually contribute the token to the ASL. So Michelle, I think you're going to step through what it looks like in BP
Yeah.
and the steps that prescribers can go through.
Yeah, no, just to be clear, though, this is nothing to do with active script list, because right now we're not actually set up at the best practice end, I think, as well, for active script lists. Am I right in thinking that, Ben, that that's an issue still in primary care?
Look, the best thing to say is we just need to focus on the SMS and the email one.
Yeah.
At this point, and everyone needs to be aware that the active script list is coming to a postcode near you, and it's just another avenue to do an e-prescription.
Yeah. Yeah. So this is just very quickly just to show how easy it is in best practice. So you create your prescription in the usual way, or you tick it if it's a repeat. And then once you've checked with the patient how they want to have it delivered, you have a new box that has appeared called eScript. And next to that's a drop-down box. Then you just select which one you want to do. And then you click the eScript, and then normally it pings on the other side of the room or on the other side of the telehealth. And you can confirm with the patient that they've received their SMS or their email, and there you go, happy days. This is just the looking at, you can actually preview what you're prescribing and what it looks like before you do it. So there is if you click on the script in best practice, then it gives you this pop-up box and you can preview it and then send it. And then these are your little options in your box, again on best practice. So paper, SMS. Now there's an SMS other and an email other, and if you click on those, so if you've got, so for example, I had a parent and child, and instead of using the parent's email address, I wanted for some reason to send it to the child, then or whatever, whichever way they want, whatever the patient wants, really, then if you go to other, then another box will come up and you can just type the details into there and send it straight away. So those would be the boxes.
I think patient choice is the key there.
Yeah.
And pharmacy has the same ability. So,
yeah.
When there's a carer and they request that they would like to do that with the patient's consent, then the same is possible at the dispense end.
Yeah. And I suppose if you had a pharmacy where you had an agreement already to email us a script, the patient wants you to email the script direct to pharmacy, which we're not really encouraging. But if the patient had that set up, then that's the way that you would do it. With email other, you'd have to use that box, but it's not really the plan. And yeah, then you just get a little notification after you've sent it. You have to click on the eScript box, you get a little notification saying it's gone. So straightforward.
As you said, Michelle, you visually see this on your screen, and you'd normally hear the patient's phone bing at the same time, even on telehealth.
Yep. Yeah, well, they start pressing the screen sometimes on telehealth.
How long does that take to get through to the patient?
It's pretty much straight away. It's pretty much straight away. You send it, and then there they are touching the screen to see there. It sometimes does mess up your telehealth slightly, so
okay.
Just watch out for that.
So maybe you could just introduce what the patient might do next from a prescriber's view.
So, well, what I tell people is that, so if people have never heard of it before, then I sort of just say to them, well, you receive a token via SMS, and then you get an SMS, you click on the link and it opens up a QR code. And that's pretty much it. You can then forward that, or you can screenshot it and forward it. If you wanted to send it on to somebody else, like if you're in isolation, for example, and you needed to send it on to somebody else to go to the pharmacy on your behalf, then that is possible without kind of printing anything or doing anything else. And if you have one of these apps, so I think you're going to talk about it a bit as well, Ben, but I think MedAdvisor is one of the most common ones. That's what the picture there is. Then the app sort of sucks up the token. That's not the technical term, but the app detects that a token has been issued and then can open it directly in the app. And then the apps can then communicate with the pharmacy?
Michelle, it does integrate seamlessly into the apps, and a lot of patients already have them, particularly those patients who have their scripts on file in a drawer at the pharmacy already, and they just order prescriptions from home and they request that it's delivered to them, or I'll pick it up in an hour or later this afternoon. So from the patient's view, it's probably not a big change if they're already using an app.
It's probably easier to have an app if you've got multiple tokens, isn't it? So if you're generating a whole load of prescriptions and suddenly somebody gets 6 SMSs, one with each item on it, it does actually say what the item is, even though it doesn't say your name, it just has your initials, but it does say the item as you showed earlier. It showed up that it was amoxicillin and things. So you can tell if you're scrolling through your messages which token is which, but you can see that could be a bit clunky for people. So the app maybe is more useful if you've got multiple tokens.
And pharmacies' experience is that if it's 1 or 2 tokens on their phone, it's quite manageable. Once the volume increases, having it just on the phone, not via an app, is a bit messy. And of course, it'll depend on people's literacy as well. And of course, with active ingredient prescribing now, those tokens actually come through with the generic drug name, which can cause some confusion. So in the app, it will tend to run with the patient's brand that they're familiar with. So there has been some evolution. If the patient's not coming into the pharmacy, the e-prescription now has an extra feature. How can I get this prescription dispensed? And I just thought it was helpful for prescribers to know what happens when you click on that. So it brings up the 2 options: bring it in person to the pharmacy, or do it remotely. And this is just to demonstrate that pharmacies have been used to pretty much having the patient come in the door for their script, or it comes, let's say, via fax, or it's in the drawer when the patient rings up and says, oh, I want to get X, Y, and Z today. There's a whole bunch of new mechanisms to pharmacies, and they're generally getting accustomed to that workflow. And I just thought I'd give you an idea. So if the patient's remote, they can now send their script via MedView Patient Connect. They can click and send it via WhatsApp. There's an AI component to that. For instance, you can just put in your postcode. It gives you the closest handful of pharmacies. You select you want pharmacy 2, and all that can flash up on the screen at the pharmacy once the patient's ordered. You can see the multitude of apps here as well. Michelle's already mentioned the MedAdvisor, My Pharmacy Link, MedMate. Now, most of these, and you're familiar with all the standard brands, no doubt, most of these have a function where the patient can elect to have it delivered as well, which is not necessarily the pharmacist's preferred choice because they tend to like interacting with their patients. But in COVID times where they're trying to reduce footfall, the deliveries have naturally increased. So at the pharmacy, their perspective, most of the software, the e-prescription actually comes up in a representation that's like the paper prescription. So it's that part of it's quite familiar for dispensers. And Michelle, you might want to talk through some of the trouble points or pain points you might have had and how you've worked through them with people.
Yeah, there's not really much, I don't think, but one thing is if you've accidentally deleted the token off your phone, which getting multiple tokens probably doesn't help with that. So if you've accidentally lost, if you lost the token, then the original prescriber has to reissue it. No one can do that on your behalf. You have to do that yourself. So if you've gone on holiday, then somebody's going to have to start again. But that shouldn't be too big a problem, really. But anyway, just so that you're aware, if it's lost after the original dispense, then they should have had their repeat token that's come from the pharmacist. So it can then be, you can get a new token via the pharmacy. So the prescriber's not involved again at that stage. So we talked a bit about deleting. I think that's actually a helpful thing rather than a pitfall, but you just do need to know how to do it. And it is a new thing because we haven't been able to cancel prescriptions before. So just knowing how to use it. And interestingly, often, consultations end with the giving of something to the person. That's sort of historically been how consultations end, whether it's a patient information leaflet or a referral or a prescription. So I'm finding that a bit with telehealth as well. It's like it ends with me summarizing and saying thanks very much and bye now. So sometimes you do need a bit more of a prompt to finish the consultation rather than handing over the script, which is interesting. It's just the evolution of medicine.
So prescribers might find new ways of ending their consult.
Yeah,
eh?
like standing up, or I don't know. No.
Very good. So look, just a couple of screenshots. How do you cancel an e-script?
Yeah, so that's just you just have to go into past prescriptions. It's really straightforward, and it's just a couple of clicks, and done. Easy. Document the reason you did it would be my tip. Don't just do it without a really good reason.
Yeah, that's, I think, the standard modus operandi for all of us as clinicians, isn't it? Document what's occurred. I just wanted to touch on some obligations, and we've mentioned, well, what I recommend to pharmacists and to the doctors I've interacted with is have a look at the legislation, particularly around Schedule 8 and S4Ds. I think once you've eyeballed the summary, it's clear in your head what has changed compared to a paper S8, for instance. So look, just to help so you don't have to look too far, on the ehealth.coach resources page, there's heaps of stuff. It's all free. It's just designed to make clinicians' life easy. And for instance, you could just click on this legislation, go to New South Wales, and you'll feel like an expert in about 30 or 40 seconds on what the legislative changes have been. Look, there is a requirement to have in anything digital, whether it's My Health Record or e-prescriptions or any of the other programs that will move forward. There is a requirement if you participate to have a security and access policy, a related privacy policy, and a data usage policy. So they're actually on the Department of Health's website. But again, you can just go to eHealth Coach and you can just click on them. It'll take you straight there, and you can make sure that you've got those policies in place so that the staff and you can adhere to the relevant procedures and processes that are required. So did you have anything you wanted to add on that, Michelle, at all?
I don't think so. No, that's all good. I mean, the ADHA has various sort of how-to videos and those sorts of things, doesn't it? So, and the RACGP has got some e-prescribing how-tos as well. So.
Yep, and we will distribute the slide set, and the PHN will have that on their website. And there's actually going to be some specific links to RACGP, as you just mentioned.
Yeah.
So I just thought before we wrap up and take, Peter Mullen's going to just run through some setup requirements, and then we can take some questions. I just thought it was an opportune time to give you an insight of where it's going. Now, at the moment, only pharmacy software can register a patient for the active script list. In the future, that will be possible from prescribing software, but I'll give you a hot tip. You'll probably just let the pharmacies do it because there is a bit of admin involved and you probably just don't need to go there. But you will have the ability to do it in the future through your various conformance software. So the active script list is not necessarily something that the patient will agree to immediately because it's new, signing up, don't understand it. So pharmacies generally would have a patient-centered, culturally responsive approach to how they might approach this with customers. It's not a loyalty club, sign you up immediately, you get all these benefits. So it may actually happen over a number of visits. And I would expect that patients might go to their GP or their specialist and say, is this actually all right? So because a token or a token contributed to the active script list are under the same security with identifiers for the premises practitioner and the patient, and there's significant security around that with the NASH encryption plus conformance software, they are safe and secure. So that's the first point to take home. So this is actually a screenshot from my phone. I registered for an active script list on the 14th of May. So the pharmacy that I registered with, I got a text and I could reply, 1, yes, I want to do it. 2, I want to do it just for 24 hours or no. And if I want to click on the terms of conditions, then I can. So bearing in mind, this isn't for every patient and we still have paper prescriptions. So if a patient doesn't have a smartphone, they really can't run through this process. So that's something to be aware of from the beginning. So if you authorise, there you go. I pressed 1 at the time. I get a second message. Do you agree that all active prescriptions, including those written prior to today, go up there? And I consented. So that means electronic prescriptions go up there, plus all the previously written prescriptions that would have had a barcode on it with ERX or MediSecure. But those previous ERX and MediSecure ones, the pharmacist still requires the paper script to dispense them. So even though they're viewed on the active script list, they can't be actioned if they're a paper script without the piece of paper. So finally here, a little bit later, I went to a different pharmacy to get a script and I selected to go on their active script list, but I selected number 2 just for 24 hours. So in general, the patient's probably going to register, then they're going to consent full time for their main pharmacy. And if they go to other pharmacies for whatever reason, then they could choose to have forever consent or just for 24 hours. So I hope that gives you a bit of insight. I've written here, collaborate with professional colleagues. There is a bit of a workflow issue for pharmacists because if they have e-prescriptions on the active script list, plus they have a few prescription repeats that might be in the drawer that the pharmacist still has to get out, plus you write them a new prescription that's a paper one, it's a very clunky workflow for the pharmacist. So if you have the opportunity to have an interaction with your local pharmacist and say, how's it working for you? Is there a way that we can streamline the admin? You might hear some pharmacies suggesting, look, next time you write prescriptions, could you do them all as e-prescriptions? And they will just automatically go up to the active script list. And that might just save a lot of paper going back and forward with this new electronic world. You're probably not going to do that though for an authority prescription. The paper one would continue as we'd all expect. I'll touch briefly on the privacy framework, just so you've got a visual really. Now, the active script list is the broad name for our country. The so-called branded version at the moment is MySL, My Script List, and that's what actually comes up in the text messages. So most patients would call it My Script List rather than the active script list, just so you know. So there is a privacy framework. It's very similar to most other digital programs for our nation. One of the pages, page 6, is outlines it for prescribers. Probably to set your mind at ease, you probably don't need to worry about it at this point, and you probably may not need to worry about it too much in the future. Most of the time, it's the pharmacies that will actually be registering the patient for the first time for an active script list. Very briefly, there's 2 levels. If the pharmacy knows or doesn't know the patient, if they've got a government issued ID, let's say a driver's license and their Medicare card, they can progress. It's pretty simple. If the person doesn't have ID, then there is a known patient. You've been my customer for years. I know you, just show me your Medicare, and they can actually do that as a level 2 known patient consent process. If they don't know the patient at all, there is a requirement for a 100-point check, and it is necessary for registration that if a patient is on a Schedule 8 drug, they have to go through a level 2 unknown patient process for their initial first time registration. So what that'll mean for most is maybe a driver's license, their concession card, and their NAB or Commonwealth or Westpac card, and they're away. So for lots of people, it's not a big imposition that they might bring in next visit, for instance. If the patient hasn't got a driver's license, there's a whole bunch of other options. And of course, if this doesn't work for them, they can just get a token on their phone, or you continue prescribing them paper prescriptions. So it's all to do with patient choice in many regards. So I hope that makes sense. And Michelle, I might just hand over to you for some FAQs that you've come across.
Yeah, thanks, Ben. So I was just going to clarify, when we get going with active script lists, I know it's not right now, but when we are there and patients are going and getting registered with their pharmacy, then as a prescriber, then that means I don't actually have to think about the transmission of that token to the pharmacy. That's
Michelle, I'm going to intervene, and you're right. So if today my pharmacy registered a patient and they consented for me to be their provider, when they go to you next visit today, it will actually flash up on your system that this patient has an active script list, and you would need to get their consent. They would press number 1 on their phone to do that consent. And when you prescribe, their script can automatically go up to the active script list.
So when we get there, yes, but we're not actually there with lots of our patients. But this is the future for prescribers, that they won't actually have to think about faxing or emailing or SMSing tokens. So this is what we need to do for now, for maybe the next year or something, as we transition and more patients and pharmacies come on board with active script list. But we're not going to be doing it forever. That's the idea. Am I right?
No, the clunky admin around faxing and posting and all of that paraphernalia, that can reduce if that's the choice of the practice, essentially.
And the patient.
And the patient, definitely.
But the patients can still have tokens to their phone for a single item or something. Active script list is going to come in more for
Yeah,
for
and
people who
look,
are
it
on
is
12
early
medications.
days. It is early days for it. We're all getting used to it. So that's why I suggest interact with your professional colleagues, talk with your pharmacist. Doctors and pharmacists usually have really good local relationships. So this is probably a conversation worth having. But as I demonstrated earlier, 3 weeks ago, 30,000 Australians had already registered for an active script list. So it is possible.
Yeah, great. So whilst we've been talking, probably everyone's already read the answers to the FAQs, so I'm not going to read them out again, but really, you know, it's centered on patient choice. You know, anything that you can do on a paper script, you can do with an e-script, so authority scripts, all those things, like we said before. And yes, we are trying nearly always to get the token to the patient in whichever method they choose, rather than bombarding the pharmacy directly. And the SMS are free of charge at the moment. Look, that might change, but right now it's still free to send tokens by SMS from clinical software. So that's that bit.
Excellent. Look, I'm going to wrap up very quickly, and I alluded before, there's really only been a few avenues that scripts have come to pharmacies traditionally, through the door, through the fax, or patient rings because it's on file. E-prescriptions are an enabler for a whole lot more, and pharmacies, apart from getting them maybe through the app or a platform like WhatsApp or via email, because there's no identifying details on a token, technically they can go through Messenger, and lots of pharmacies have Facebook. And look, there's so many apps that are out there, and a lot of them involve deliveries, that there's going to be a whole new bunch of ways that patients might actually get their script to pharmacies. And pharmacies are crawling before they're walking. They're adjusting to this new paradigm. So just something for prescribers really to be aware of. For the specialists in particular, there's a digital health specialist toolkit created by the agency, very comprehensive, supported by all the key organisations, including the Australian Association of Practice Management. So there's practice managers modules as well that are quite helpful. Free again on the eHealth Coach resources page. There's links for some of the different software vendors. Of course, you can just ring them, but if you want a place to go, if you're on multiple platforms, then this has just collated it. And Michelle, I think these are your links that'll be shared in the notes that people can investigate later. Terrific. So, Michelle, is there anything you want to say to finish up with?
No, I think that's it really. We'll hand over to Peter with the practice management side, and then we'll come back for questions, I think, at the end.
Excellent.
Thanks, Madam Michelle. Can you see my screen there now?
You certainly can.
Excellent. Sorry, just getting things organised. Alrighty, that was great. Okay, I'll just run through very quickly some of the foundations for prescribers and what underpins e-prescribing. The first, and obviously it's been talked about earlier, is the Conformance Software. In GP land, obviously the two primary pieces of software, your BP and your MD, or Helix for MD, they are conformant. Some others are the Shexy Platinum and ZMed. In the specialist world at the moment, probably the main one that's not there is Genie. I believe they're working on it and it shouldn't be too far away. They had hoped to get it in by the end of September to make that change in the image-based prescribing being removed, but I can confirm that that actually came out in the last couple of days. That image-based prescribing will extend to December, end of December. And hopefully Jenny will be on board by then. The other thing you need is a prescription delivery service. And there's only two, ERX, Script Exchange or MediSecure. A lot of people will already be familiar with those companies. and using them. You know, the easiest way to check if you've already got a relationship with them, if your paper scripts are printing a barcode at the moment, that tells you you've got that prescription delivery service already installed. The other thing to just keep in mind with the PDSs is that it is an individual registration. So while you register as the practice, you've got that individual registration. So you need, if you get a new registrar or a new doctor into the practice, they need to be registered at your practice. So make sure you contact the PDS and let them know.
Peter, for the Conformance Software for specialists, for any specialists on our webinar, 20 of the specialist software vendors have actually been funded to get conformant. So that is actually in progress.
Yeah.
So I think that's just a message that's worth sharing. Thanks.
Yeah. They'll all be not too far away with hopefully, so that'll be good. Okay. HPOS and PROTA. Look, HPOS and PROTA really underpins, it's the linchpin for so many interactions with government agencies and a lot of the digital health activities. So it's important that you've got both individual and organisational PROTA accounts set up. So having your HPIO, your health provider identifier for your organisation, and when you've got all of those things set up, make sure you've got the appropriate designations and delegations. So if you're the responsible officer, you're automatically made an organisational maintenance officer, or an OMO, but make sure you've got an OMO if you're a larger practice or even a smaller practice, because it means you've got that just, business is easier, you've got that ease of doing business, you don't have to do it all yourself as the RO, and also business continuity. If somebody leaves, if you've got more than one OMO, it just means you've got that ease in business continuity as well. So just keep that in mind and make sure you've got the delegations right for your own organisation. The other thing is that you don't need to have an HPII, so a health professional's individual identifier, to be an RO or an OMO. Registers with the health identifier service, and also obviously you need a current national PKI certificate or request one. So getting a NAS certificate is now all done through PROTA and HPOS, and there were some changes coming along later in the year. It's critical that you actually have PROTA and HPOS set up, because there will be some changes to Medicare claiming online. It's moving to what they're calling web services, and that will all revolve around that as well, but there'll be more to come on that down the track. Just some general considerations. Ensure that your patient demographics are up to date in your clinical software. So make sure you've got the right phone numbers, mobile numbers, email addresses, so that when you're sending the tokens out, they're going to the right place. Make sure you've got your IHIs in your patient files, and obviously that revolves around having that health identifier lookup available. And also make sure that the team's been trained in using the software for e-prescribing. If you get new staff in, make sure they're aware of how to do it. If they may have used it in MD before, you're using BP or vice versa. Make sure they're aware of how to do it, how to revoke a token, how to cancel one, and all that sort of stuff. And that they're aware also of your procedures in the practice. Do you send it direct to pharmacy? Do you not send it to pharmacy? Make sure you help new staff out. And do you have the right policies in place? Ben and Michelle mentioned it earlier. Everything requires a different policy. You've got a policy and procedures manual. Make sure these policies are up to date. I put my health record there because I believe there's been quite a bit of contact lately into practices asking for copies of their My Health Record policy. So make sure you've got those in place and that they're up to date and that you're following them. I've put up some more links. We've drowned you in links tonight, I think, but there's a lot of good information out there. So some links here again. These are just all the links sit behind these. So when you get the copy of the presentation, you'll be able to get that information out there. I might quickly jump off now. Oh, actually, no, I'll mention one more thing. Sorry, SafeScript New South Wales. This is just more an advert for what's coming down the track. SafeScript New South Wales is a real-time prescription monitoring that's coming in. It's going to be trialled in the Hunter, New England, Central Coast regions from late October. And there'll be a lot more information to come out there. You'll see the link there to safescript.health.newsouthwales.gov.au. So there's some information there. And also we'll be updating community health pathways. So there'll be some information there as well. But we won't get too much into that tonight. We'll cover that in a further session. And I might hand back now and let everybody ask some questions.
Yeah, we've had a lot come through. We've covered a lot of content tonight, so well done. We're running a little bit over time, but I'll move through the questions as quickly as I can for you. So The first question that came in was, if the patient chooses to retrieve tokens via paper and then loses it, can that be reprinted, and where is the repeat stored? Who's going to answer that one?
So if they've received it by email and they've lost the printed version, then they can still reprint the email. Yeah, but they can't use the token twice. Does that make sense? So if you've
Yes.
printed it and had it dispensed and then lost it, it doesn't matter because it's useless. So although it does have some patient identifiable information on it, so I would want that shredded. Yeah, so the repeats would come through the same method. Does that make sense? So from the pharmacy.
Yep. Okay. Where on the iPhone does the token live?
Well, it comes, if it's sent as an SMS, which is about 2/3 of e-prescriptions, it just comes in as a standard message with that hyperlink. And if they press on that hyperlink, the token will come up in their phone. It's not really stored in a wallet. It just comes up, for instance, on their Safari browser. If they have an app, and we mentioned MedAdvisor a few times, it will just integrate into that app.
Okay, great. Can e-scripts be used for Webster packs?
Yes, they can, but there's the issue of how are you going to get it to the pharmacy, and how are you going to actually communicate with pharmacy and make sure that everything works. So there's nothing stopping you using them, but you have to have a conversation with the pharmacist.
Yeah, look, very few patients are on 1 or 2 medicines on a Webster pack, of course. They're going to be on their handful or a dozen, and really the active script list will be more suited for that type of person. I think that's probably the clearest answer, isn't it, Michelle?
Yeah, and I think if you are in a situation where you normally would fax scripts to the pharmacy, fax printed scripts to the pharmacy and then post them out, then I would encourage you to have a conversation with your pharmacy about printing tokens and faxing those, because that's much more straightforward. So if you already have patients for whom you do that, then I would say your workflow is much easier if you just print the tokens and fax them.
So if you print the token on a paper, it will have evidence of prescription on the top. It should have the patient's name and the doctor's. So it's actually got all the identifying details.
And then I scribble on the bottom which pharmacy it's going to. Job done.
Okay, there's quite a few questions about elderly patients who don't have that sort of technology or mobiles, and just asking how to handle those.
I think that
don't change them from paper. If it's going to cause confusion and hassle, just do what they've always done.
Yeah.
Yeah. Okay.
Because this is interim as well.
Oh, sorry. How do you cancel an e-script?
Oh, before we go on though, could I just add, some elderly patients may not have that capability, but their carer might, their son or daughter. So if the son or daughter is actually in the consultation and there's consent, well, there's no reason Michelle couldn't put on the son or daughter's mobile and go through the consent the consent process for all the scripts to go up to the active script list. That would make sense as time goes on.
Yeah.
Okay. How do you cancel an e-script?
I think we jumped through those steps. So
yeah,
in your medical software, it is straightforward.
Can I just add though, a pharmacist can't cancel it.
No.
And another prescriber can't cancel it, only the original prescriber.
And same for reissuing.
Okay. If an e-script is set to default and does not dispense the doctor's script, how do they get around that, or any other tech issues? Who do they talk to?
I'm not sure about the setting to default bit, because you're picking how you do something each time. So you don't set a default and then forevermore, or at the moment you don't anyway. Maybe that would happen in the future, but certainly at the moment, for every single item you dispense, you choose how you're going to. Oh, sorry, every time it's not dispense, prescribe. Every single item you prescribe, you pick your method.
Yeah, I agree with that. Per episode, it's decided each item.
Yep.
There isn't a default.
Okay. When does the SMS subsidy end?
Peter?
Yeah, it's been extended through to the end of June next year at this stage. So watch this space. Whether it continues after that, I don't know. But indications are, I know from BP that I looked some time ago, it's only going to be 4 cents per script or per token. So it's not a huge expense. And I think if most practices looked at it in the cost benefit analysis of what they're going to save in time and consumables, it probably weighs out fairly well for them anyway.
It's a lot cheaper than a stamp. If you're having to, if you're faxing and then posting scripts, it's an expensive old process, time consuming.
Yep, and still cheaper than a fax.
To add, Peter, the bigger picture is the department probably haven't worked out the full cost to them for the committing to it forever. So that's actually a work in progress. So as I agree, as you said, it's in place till the end of June this year. I think while they actually work through it.
Okay, what is an active script list?
Hopefully we've covered that, but you'll know it as my script list. And I think the easiest summary is that if you've got Conformance Software with NASH encryption, with the identifier for the premises practitioner and patient, the script goes up to the secure cloud, and then the pharmacy, when they scan the token, they, with all the same components in place as the prescriber, they can draw it down from that secure cloud as the legal script. So it doesn't have to go to the patient.
Okay,
Yeah, so I suppose, so the I can't really think of an analogy, but the best analogy I could think of when I was trying to work this out in my head was, you know, like I've got wallet on my phone that stuff goes into, and it all sits there, and I don't have to go hunting for it. And I guess in the pharmacy, instead of having to look in a drawer and having to look for all these different methods of delivering tokens, the tokens will just be on the active script list. For the patient, they don't have to deliver bits of paper or find their token. It's on the active script list. For the prescriber, they don't have to print out a token, fax it, print the script, make sure the patient's got an SMS. It's just on the active script list once all of those things are in place.
And I think you've nailed it there, that basically you put, it doesn't matter if you're a prescriber or a dispenser, where there's an active script list, you put in the patient's name, you click on it, and all their items that are live come up, whether there's paper scripts or electronics. So there's a visibility. I mean, now you carry around your 4 or 5 repeat folders and your original script, and it's just a mismatch of paper, but it'll be very accessible, just pop-ups immediately on your screen as a prescriber or dispenser.
Okay, can we do scripts with CTG included?
Yep.
Definitely.
Yeah.
Any script you can write on a paper can be an e-prescription.
Now with closing the gap though, you need to have registered them via Proda. So once it's a once-off thing, that's my understanding. Once you've done it once, it should be there forever. So you don't have to keep on thinking about it. So.
Okay.
Sorry, sorry, Peter. What was that? Sorry.
Yeah, you're right, Michelle. They don't need to re-register. It's a one-off. So.
Another tick for Proda.
What about reissuing scripts electronically? If the patient has deleted the SMS or the email, what happens in that situation?
Original prescriber only, and you go back into past prescriptions and you can reissue it, but only the original prescriber.
I'll just do a clarification from the pharmacy side. If it's a repeat, let's say they've had 3 dispensings already, then the pharmacy who did the last token can reissue the repeat.
Yeah.
But yeah,
So
if it's the original, it's only the initial prescriber.
So if it hasn't already been dispensed, it's the GP's job. And if it has already been dispensed, then you can redirect the patient to the last pharmacy that dispensed it.
Okay. Then I've got why do some e-scripts not get sent? I've had 2 e-scripts sent to patients and one goes and the other doesn't.
Don't know.
Not sure.
That
No.
might be
An issue.
yeah,
Or
the telecommunications issue. I would suggest it certainly, as far as we're aware, the system is pretty rigorous.
okay. A couple of questions around nursing homes. How do I do nursing homes?
To be honest,
okay.
right now, I'm not sure I would try.
Yeah. Okay. Peter's introduced SafeScript New South Wales that's coming. At the moment, there is a national residential medication chart, which is a paper form and can last as a 4-month prescription. There is an ENRMC, an Electronic National Residential Medication Chart, where there does not have to be a signature on it, and it is part of the electronic prescription, and that will be part of the next release, which is the final release for electronic prescriptions. So the brief answer is keep doing what you're doing today and tomorrow. However, can we say there's a brighter future, that it will be more streamlined with electronic prescriptions and the ENRMC, the Electronic National Residential Medication Chart?
So there is hope that one day people won't have to write the same thing in lots of different places for aged care facilities.
That's how the conformance profile is built. And you might remember when I showed the digital agencies map before with the 44 objectives, that's one of them. And remembering that we're trying to bring our little nation of 26 million people with 600 bits of software that don't talk to each other, we're still trying to bring that together. So we're far from a perfect system, but we are making significant gains, particularly in the last few years. And I suppose I say if there's a couple of clunky difficulties, then that's part of the transition, unfortunately. You know, if we only had a dozen systems, we would have knocked this over years ago, but we don't.
Okay. I've also been asked to mention that there's an electronic prescribing resource page on the Health Pathways page that has those links, but also the presentation will be available in our education library for everyone to access, as long as a copy, along with a copy of recording for tonight. How do I get a password to prescribe S8 drugs? Lots of questions coming through.
Oh, that's just your. So if you're in best practice, you just put in your best practice password when that comes up. You don't have to do something extra. So I assume it's the same in Medical Director. You just have to re-enter your password for that.
Yep. Some pharmacies are
Can
not.
I just say on that, if it's like a 2-step authentication, isn't it, Michelle? Because you've already logged in, you're already doing what you're doing, but as you do that S8, it's asking you to do it as a 2-step authentication.
Yeah, it just takes a couple of seconds. It doesn't take anything like as long as having to write on the script.
That's a positive. I'm finding that some pharmacies are not sending the new code for remaining supplies back to the patient with repeats on them. Is that something the GP should be talking to them about, to the pharmacist?
The pharmacies ought to be remedying that themselves, and just like a prescriber would do an e-script, do a token and say to the patient, just making sure that you've got it there on your phone, the pharmacy's best practice would be that they double check that the patient has the repeat. And if they didn't, deal with it at the time.
Because that happens at the time of dispensing. So when you're dispensing,
same as yours, it's instantaneous.
It's instant. So as it's being dispensed, then your repeat should be coming back onto your phone whilst you're in the pharmacy.
So the extension to that answer is they've stuffed up something in their setup. They may not have ticked a box, for instance, and they would normally contact their dispense vendor and correct that, and then it shouldn't happen again.
Okay. We've got so many questions coming through, and we are over time, but we'll just do a couple more before we end. Our MD has a default, but you need to then, pick a print script. If there's a default set in a demographic screen, how do we handle that? And can you see how many times a patient uses the script? How many repeats are left on the script?
No, you can't. Okay. You can't. So as a prescriber, once you've done it, you can't see it any more than you can see your paper script if the paper script is not brought back to you. So you can just see when you last issued it and how many repeats you issued. If you, of course, if you've got permission, you go on the MHR and you can see how many times it's been dispensed. If you've got a patient with you and you get their consent to do that, you can see how many times it's been dispensed. I've used that a few times.
Michelle, just to add into that, because the health identifier service is involved with e-prescriptions and it's involved with My Health Record, and all the pharmacies are connected for e-prescriptions, nearly every dispense goes up to My Health Record. So for any visibility, that is the conduit to see the history of dispenses. And a point of clarification, Michelle, for the 23 million Australians, I think almost 92% of Australians with a My Health Record, if they have a My Health Record and a clinician is providing care, there is standing consent to view that.
I still ask them though, just in case, like whilst they're there. I just say, I'm just going to check on your My Health Record. Is that okay? Yeah, there we are.
Yeah, and look, that would be best practice indeed.
Okay, and the last one, why does the script not appear for every patient?
Maybe if it's not turned on in your clinical software. So I think it appears as it either appears as an option or it doesn't. It wouldn't be patient specific.
It would be if they don't have an IHI in their demographics.
Oh, yeah. So you can't practice on test patients, can you, Peter? So when I started doing these, I tried to do it on test patients who don't have an IHI, and just ended up having to do it on myself, send myself prescriptions to practice and cancel them immediately, just to see if it all worked, because you've got to have an IHI. Yeah,
that's right. There's no test beds for this. It's only real people. And I just wanted to go back to Peter's presentation. The foundation for this is setting everything up 100% correctly. You cannot do it 90-something% correctly. The setup has to be exact. So that's where you can work with your vendor, understand the pro to HPOS story, because if you've got that right, this will just flow, is generally the experience. But people have problems. It's that initial setup step where there's something missing.
Okay, well, thank you so much. There's further questions, but I will forward them to all the presenters to have a look at as well, at the questions we haven't had time to be able to get to, because there has been a huge amount of questions come through, which is great. So thank you all for being here tonight and presenting on. There's been some great content covered. And it's been a really interesting session. So I want to thank everyone for being here. As I said before, it is being recorded. It will be available in our education library along with the presentations as well, and also refer to your Health Pathways page as well on our website. So thank you. Thanks, Michelle, Ben and Peter for being with us, and we'll see you next time. Thanks. Good night.
Everybody.
Thanks.
Thank you.